Assalamu alaikum, peace be with you. Bismillah, in the name of God. I want to just share some reflections from some of the work that we've been doing in the UK and think about some possible implications for the US. But before I get going, I mean, just incredibly grateful for you turning out on a Sunday morning. I appreciate that. And I'm very grateful that I've got two wonderful colleagues, Gordy Schiff and Marge Cohen, who've joined us. They're in Boston now and again, but their hearts are really in Chicago, where they've done some absolutely fantastic work at Cook County and are really, I think, leading figures in the work around disparities, which is something that we're discussing here today. So on the menu, and I'm going to have to try not... so what I've got is, what I want to do is go through this, begin to describe the Muslim community, and some of the work that's gone into actually getting us there. Try and summarize what we know about Muslim health in the UK, and it's not easy, largely because of a lack of data. So a similar issue to some of the issues that you're grappling with that became evident yesterday. I want to then talk about some of the work that we've been doing to try and improve the health of Muslim communities. And most recently, some of that work is extended to a bit more of a global footprint. And then I'll wrap up, and I hope there will be time for questions and discussions, although Asim and Stephen, I was originally told I had an hour, but on the program it's 45 minutes. So let's see where we end up, really. So just a bit of context first. So I did introduce myself briefly yesterday. So I was born in Karachi and I was moved to London when I was 1. So I had no choice in that, but clearly that's where I grew up, in the East End of London, and that's where the majority of migrants have actually come in to the UK. So we've had waves of Jewish migration there, Muslim migration, most recently Eastern European migration, and so it's really been the entry point into the UK for minority communities in general. In terms of what I've studied, well, physiology and medicine and epidemiology, and also work around health policy. So, I think I'm a bit mixed up, as you can see, really, from my research interests, but that's me. I've also served as chair of the research committee of the Muslim Council of Britain, which is the main umbrella body for Muslims in the UK. So a bit like ISNA, the Islamic Societies of North America, or ICNA, but it probably it's a much younger entity, and still really finding its feet, and that was a privilege. And I've been in really this absolutely stunning city since 2003. And I've heard some of you had the chance to come to the UK. Well, if you get the chance to come up to Scotland, that will be absolutely fantastic, because after Brexit we will need all your dollars, really. So please do come and spend some of your money there. I got to know the US a bit. I absolutely love this country. It's a fantastic place. And this was the road trip that me and my family took a few years ago. So it's New York to San Fran, and then San Fran down to San Diego. So, absolutely gorgeous country, and lots of wonderful friends here. But I don't claim to understand it completely, because how on earth could you elect the person that you did, really? In terms of my first foray into all of this, thinking about religion and health and its intersection, came from a very practical place. And so this was really, a couple of years after graduating, while I was doing what we call in the UK the house jobs, so your first clinical positions. And what I was trying to, and these are busy jobs, as you know. For those of you who work clinically, it's absolutely the same here. And there was nowhere for me to pray. In the end, it was corridors, or an empty theatre, or whatever. And so what I did is I raised this, saying that what there needed to be was a place where people could express their faith, and not only for patients, but also for physicians. So that piece was published in the British Medical Journal, and it was picked up on Radio 4. So Radio 4 is absolutely fantastic radio listening. It's a bit like NPR. So and it was raised sort of publicly, and as a result of a lot of other things that have happened, so I can't take complete credit for this, but what we now have is 20 years on, we have prayer facilities really in every hospital, across the UK. So that's, and the way, I thought about this was that these need to be inclusive places where people of any faith or no faith could actually step out of what are busy, challenging roles and actually have the opportunity to reflect. So the idea that was put forward was the idea of quiet rooms. So Deming, and I put this up because, we're going to be talking about data quite a lot. I tried to emphasize that yesterday. I do modify this for this audience because, the prophetic tradition is also, I think, incredibly important for us. But data I'm going to be talking about because I think data are incredibly important if we're going to make a cogent case. So let me turn to the beginnings of this and in terms of what do we know about the British Muslim community. So overall, it's a relatively young community. So Muslims started coming to the UK in large numbers in the 60s and 70s. And these were predominantly migrants from South Asia. So following the old colonial links, there are people coming from India, Pakistan, Bangladesh. Subsequently, there have been waves from other parts of the world, the Arab world, for example, parts of Africa, some European Muslim populations. But still, the bulk of that community came, and they came to do the jobs that nobody else was willing to do. So they came to work in the mills, in the cotton industry, to work in the railway industry. So these were working class. It was that group of people who were attracted to the UK, for whom sort of migration was made relatively straightforward at the time. Now, how do we begin to sort of make sense of what's a relatively young, pretty diverse community? And there are a number of challenges if we want to sort of grapple with this issue. Number one is we've got very limited data, and that will become clear during the course of this presentation. The data that we have are quite often very out of date. There's very limited resolution. So sometimes these are national or UK-wide data, there are quite a lot of definitional issues, as there always are with data. But quite often for decision making, what you need are granular data. So you need to be able to look at a state level, for example, or a smaller area level. That is, for us, quite a lot of the time, very challenging. I think also what we have are most of the data that we have, unfortunately, are snapshots. So they're one moment in time. And if we really want to understand communities, and these are communities in a state of flux, what we need is a longitudinal perspective, so we can begin to kind of look at evolution of these communities. And I think what's really important is this idea of intersectionality. So religion is kind of one hat for me. There's my kind of ethnicity hat. That's coloured actually much of my experience growing up. The UK was a very racist place growing up. It still remains that, particularly if you're in the marginalised group, the lower socioeconomic groups. So, I think what we need to do, and I think this has become evident, I think also from what we were hearing yesterday, is we need to look at the relationships between these kind of different hats that we all wear. Gender is another dimension. Sexuality is a dimension for some as well. So, I think very important issues that you guys are grappling with. So this is a piece of work that somebody like you, so somebody from the ground, a jobbing primary care physician, wanted to get involved in a research project. And she came to me and this is what she did. So she looked at the available data sets that we have in the UK, and we do have some absolutely outstanding data sets in many respects, and tried to ask the question as how many of these actually had ethnicity or race. We talk about ethnicity largely in the UK. Race is a bit of a biologically discredited term, or religion in. And as you can see, only relatively few had anything that we could begin to work with. The key thing is that she went on and published that, and now Public Health England are working to try and address this issue. It's 10 years on, so research and its translation into policy, etc., takes time. So this is a kind of a long-term game. But I think if you can get your work out there, get it to the public, then hopefully somebody will pick it up in due course. So what we have is, what I've been trying to grapple with is when you have sort of data that are, not on message most of the time, that you have to move into an interpretive mode. So what we try and do is try and make clear whatever data sources that we're working with, their strengths, its limitations. When we're thinking about Muslim health, we try, wherever possible, to use self-identified religious identity as the variable of choice. But a lot of the time that is not possible. And so what we're forced to do is then think about using ethnicity or country of birth. And both of those are problematic. But I mean, quite often, I mean, there's no other sort of handle that we can get otherwise. And if we are sort of moving to these other sort of identifiers, it's really important to think about, I mean, limitations and think about appropriate interpretation of data. And so these are some of the main data sources that we have available when we're trying to think about Muslim health in the UK. This could be an exercise that you may want to go through in the US. Well, what are the major available data sources? How could they potentially be augmented to try and answer the questions that you guys are grappling with? Right, so the most basic question, how many Muslims are there in the UK? Well, prior to 2001, nobody knew. You couldn't answer that question. Because the major sort of source of data was the census, and the census last recorded a religious question over a century ago. And so there was a campaign, and I was part of that campaign, and we worked for 10 years to get the religion question into the census. A voluntary question, first of all, in 2001, and then it was a mandatory question after high completion levels in 2011. That campaign was worked jointly on with other faith communities, because unless we could be counted, well, how on earth can you ever begin to make a case about anything? It becomes incredibly difficult. There were different solutions that came from the different nations of the UK. So slight kind of variations, as you can see in the questions, but nonetheless, there was a basic question there that we could begin to work with. And as a result of that, for the first time, we were able to quantify. And I'm very happy to leave these slides, share them, whatever. So just don't worry about taking photos. You can have the slides. That's no problem at all. So for the first time ever, we were able to quantify the number of Muslims in the UK. And this was a figure far lower than some of the sensationalist headlines that we sometimes get. But also in quantification of the other faith communities. All right. The 2011 census, and what we see is really very substantial growth. We're looking at sort of over that 10-year period, I mean, a 30–40% growth in the size of that population. Other then data providers began including this question subsequent to the national mandatory census. So other data sources began providing us more contemporaneous data. And really what we're looking at now is probably of the order of 5% of the UK population is Muslim. So a lot of work, I mean, a lot of lifting, but at least we got an answer to that question. Now, part of the reason why that community is growing so rapidly is because this is a relatively young community. And we were hearing about this yesterday from Michael and the Imam in Minnesota. I mean, what a young community you have there. Well, it's, the profile is very similar. There is also a higher fecundity rate in this population, and this is also then contributing to growth. But I mean, really, this is also a message for our Muslim leadership that what we desperately need to do is begin to understand, engage. Our places of worship are not particularly welcoming. It sounds like you've got similar challenges here as well from what I was hearing yesterday. What we have is these communities are largely really congregated or in sort of the inner cities, the downtown areas. And this really reflects the fact that what happened is that they came to meet certain needs, working in sort of labor shortages to fulfill those needs, and migration for these communities has been pretty challenging subsequently. For example, if you look at the east end of London, so Tower Hamlets, Newham, for example, for those of you who visited, 1 in 3 of the population is Muslim. These are, in effect, kind of ghettos. These are ghettos not necessarily of people's choosing, but that is the reality. And part of the reason I say that is that if you look at median income, you can see, I mean, if you've got that kind of median income, then you have very limited lifestyle choices. Yeah? So this is a poor, deprived, still pretty insecure community. In terms of part of the reason why median income is problematic is that now most households in the UK are at least 2 people working in the household. The Muslim community, I mean, is somewhat different in that respect. Right, okay. What we have is, if we look at qualification, and this was all only really ever become possible because we have the census data. So level 4 qualification is degree level and above, yeah, so undergraduate degree. What we have is that we have a lot of the Muslim community, I mean, who have no qualifications whatsoever. So invariably, if you go in London, then the Uber driver is invariably from a Muslim background. Things are beginning to improve, as you can see from these longitudinal data that we're beginning to get, but still one heck of a lot of way for improvement. Right, can I just pause and ask if I've lost anybody yet? I mean, is this making sense? I mean, I'm sharing a lot of data. I realize many of you are sort of, and this is quite a new experience. Have I lost anybody? No? No? Okay, all right. Please do let me know if I lose you. So I want to now turn to health profile. So in the census, there are only 2 questions around health. So mandatory questions. So these are the only data that we have on how faith communities are doing in the UK at a national level. Right, where are we at? Sorry, this one, yeah. So, what do you make of that? So, I mean, the question here is can you self-rate your health? And it's on a 4-point scale, so from very good or good health right through to bad health. So, sorry, 3-point scale. And 84% of Muslims are saying that they've got very good or good health. And I mean, the population is 81%. Yeah? So it looks great, huh? But what you have to do is, of course, this is a younger community. So you have to age adjust. And if you look at the data then, it's a very different picture. Yeah? Okay, the only other question, I'm trying to work out where we are, is this impacting on your day-to-day living? And here what I've done is stratified the data by younger people and older people. And so what we've got quite clearly is that this is relatively young, deprived, living in inner cities by and large, few qualifications. And so rather unsurprisingly, self-rated health is pretty poor compared with the national picture. And then there's a lot more impact on self-rated disability and by extension, obviously, things like quality of life. But these are the only data that we have overall. And so what we have to do is then begin to look at, how can you begin to infer from ethnicity data? Because there are a lot more data sources with ethnicity. So it's a diverse community, it's getting much more diverse. But 2/3 of the Muslim community in the UK come from South Asia. And one of the things that you can do is, just like we were hearing yesterday, so if you're coming to the US from Somalia, almost invariably you're from a Muslim background. Similarly, we can say if you're coming from Pakistan or Bangladesh, almost invariably you're from a Muslim background. So you can begin to use that as a proxy or as a surrogate measure. It's inadequate, it's incomplete, it's not where we want to be, but it can give us a bit of a handle on what's going on. So one of the things that we did in Scotland was, and this was led by a colleague of mine, Raj Bhopal, who was very interested his whole career on ethnic disparities. And so what he led was a piece of work over a decade to try and link census data with health data in Scotland. It's the first time in the world that's been done. So the number of permissions that we've had to work through are, absolutely, there's a book to be written on that. But this is the kind of basic schema. So this is being done on basically the entire population. So it's 4.9 million people out of a base population of 5.2 million people. So there are no issues to do with generalizability here at all. And what we find is, and these are slightly complicated plots, but basically, if you're on this plot, this is looking at the risk of, let me get onto the same one here. So looking at the risk of asthma admission. And what you can do is, the reference point here is the white Scottish population. So if you are above that line, you are at increased risk of admission. The dot or the square is the kind of point estimate. The lines are the confidence interval, so how sure we are of that. So you can see what we've been able to do this now is basically every sort of chronic disorder under the sun. We've actually also been able to do it now really for a lot of infectious disorders as well. And it's a very similar picture. So the Chinese do incredibly well on nearly all disorders. The Pakistani and Bangladeshi community do pretty badly. And by that, I mean what we're trying to look at here is the Muslim community in Scotland. So that's the surrogate. There's one where the Muslim community actually does better. That's perhaps unsurprising. That's alcohol-related disorders. But what's also, interesting is that the Chinese community perhaps do even better there. That's interesting. So maybe we've got something to learn from that community. In terms of risk of hospital admission, and this is all cause, and this is now stratified by sex. So this is in females, and what you see is, and then also for males. And really, it's a kind of a very similar picture, across the piece. But what's quite interesting is that if you look at life expectancy, this is, it's a different picture emerging here. So it's the Indian and Pakistani community. We don't have enough Bangladeshis. We had to suppress the data, so we couldn't get a handle here. But it's a kind of a rather mixed picture. So the data are not really at all what we were expecting. This is for female life expectancy at birth, and a very kind of a similar picture there, sorry. And then in terms of a summary, if we look at life expectancy across the entire Scottish population, so this is everybody, the lowest life expectancy is in the white Scots. Definitely didn't expect that. And so, data can throw up things that you do not expect. What we're interested in here are sort of not preconceived ideas, and I was kind of feeding that back to some of you yesterday. We're trying to find where the data takes us, yeah? That's what we're trying to do. So I probably am way behind time, actually. So understanding the reasons for some of these variations. So this is where I've tried to because the data are a means to an end. What we want to try and do is try and develop actionable insights to find out what can we do on the back of all of this. So in the UK, I think we're in a kind of a pretty privileged position because we do have a national health service that it's free at the point of delivery, that everybody has access to, or virtually everybody has access to. And this is a kind of a schema developed by the Commonwealth Fund. And so what we have are very, very good access considerations, and this is for everybody. And I know, unfortunately, you're not in that position. Maybe somebody will rescue and reinvigorate and embolden Obamacare at some point in time. But if you look at our outcomes, they are pretty poor, really. It's only you guys who do worse. Yeah, which is a bad position to be in. And I think the reason for this, to my mind, is that what we don't do is pay enough attention to these kind of wider determinants of health. And these are some of the things that we were discussing yesterday, so you'll be very familiar with this. And this is a report I was involved in as part of WISH, the World Innovation Summit for Health. And what we try to do is look internationally to see how much healthcare actually really matters in terms of health outcome. And healthcare is important, of course, but when we're looking at population health, it's a relatively unimportant sort of bit of the equation. So the kind of things that you're doing in the community, sort of working at the grassroots level, I mean, I think really matter. So I want to then sort of move on to what some of the data are showing and some of the kind of actionable insights. And these data are, unfortunately, they are pretty old because that is what we have available. And so this was looking at adults and physical activity. And the reason we had this, because the British Heart Foundation, sort of a major charity in the UK, in this year had an ethnic minority boost population. These are like 15 years old. They've not had a subsequent ethnic minority boost. So we do not have anything more contemporaneous. But as you can see, I mean, there are kind of vast variations there for these things that we know are important. Has the picture improved? My guess is probably no, unfortunately, but I don't have any data. If we look at cigarette smoking, and what we're doing here is, again, saying that Pakistani and Bangladeshis are sort of an inadequate, but probably the best surrogate that we have for the Muslim community. So there's, I mean, the data, I mean, hopefully just speak for themselves, and it would be better if we had a very different sort of picture. If we look at fresh fruit and vegetable consumption and portions per day, and it's again the same, but I mean, for those of you who work with marginalized populations, deprived, relatively little sort of, I mean, food deserts, it's not entirely surprising. If we look at the prevalence of diabetes, for example, I mean, it's a very similar kind of picture. I mean, these communities have got, I mean, double, triple. I mean, actually, this picture is getting worse going forward. And this was, these are data before we had any of this stuff. So halal KFC. So this is kind of the pre-fast food halal era, yeah? You know, there was a study done in Tower Hamlets. So in a sort of a 1 mile vicinity of the major mosque there's something like 300 fast food outlets, all halal outlets, yeah? So these are kind of some of the structural challenges that we need to try and overcome. There's this study that on the back of, I mean, all of these data was funded, the Born in Bradford study by John Wright. So this is taken, Bradford is kind of 50% Muslim. It's in the north of England. It's where the textile mills and industries were. So it's kind of really Pakistan, really, or its outreach. It's not really the UK. But, and so what John has done is constructed a birth cohort there. So half the population of that cohort is Muslim. And one of the things that they've identified there is, I mean, how big an issue consanguinity is. These are more recent data. I mean, it's an interesting report in the Lancet. What he's gone on and done and followed this cohort, and these are some of the most recent data that we're getting, is looking at some of these kind of feeding practices are established incredibly early on in life. So these kids are, I mean, born at advantage in many respects. They're born within wedlock. They're born in relatively stable homes. Both parents they're breastfed. I mean, the data are there, but I mean, in terms of their weaning habits, I mean, we're disadvantaging them right from the outset. It'd be interesting to see your data in that respect as well. So in terms of trying to improve health outcomes, so some of what I've been doing is I've been involved in putting together, I mean, some thoughts, working with scholars, I mean, across the UK and internationally, and these are, I mean, a couple of the books. And what we've tried to do is try and raise the profile of this. So the book on palliative care, and I've left a copy with Asim if anybody's interested of both of these, the foreword was written by the Chief Medical Officer, Sir Liam Donaldson. So that's the equivalent of your Surgeon General. So we try to raise the profile of this stuff. The Caring for Muslim Patients has been written by His Royal Highness Prince of Wales. Both of these were launched in the House of Lords. So I mean, trying to work to try and sort of raise the profile of this subject. And this is a review And thankfully, this was reviewed. And what we tried to do was move away from these kind of stereotypical, formulaic, cookie-cutter-based approaches, because no Muslims are like that, no individuals are like that. What we tried to do was try and introduce the narrative, that kind of overarching narrative with all its complexity and nuance. And so, do have a look at those. That may sort of offer some insights, I hope, into the community. Also try to raise, other sort of generic issues, and wherever possible, try to do this in the mainstream medical press. So, for example, issues to do with medical ethics, and I know Asim works on this issue. I think there's a phenomenal amount to be done. I was really interested in the poster at the back on sort of Islamic ethical perspectives on transplanted uterines, really. So, I think really interesting issues that we have to sort of get engaged in a serious way. I think what we need to do is partner with other minority faith communities wherever possible. So this was a piece of work that we did together with the Jewish Board of Deputies, a very established group in the UK, thinking about, this religious circumcision matters to both communities. There are big pushes in Europe to try and outlaw this completely. The UK, thankfully, has not taken that position, but I think we have to be proactive and begin to make the case as to why these issues are important, for example. Thinking about moments in time that, I'm just giving you some examples, but all of this is out there. So do go and have a look. These are things that impact not only sort of on people ongoing on these journeys, but also impact on the system and give us opportunities to really begin to make a difference to people's quality of life. Again, doing this wherever possible. So this is with Liz Grant. Liz comes from sort of a Christian tradition, doing this very publicly about how do we engage with this discussion around religion and health in what are effect really sort of post-religious societies. It's challenging, and I think there's a lot that we can learn and give to each other in that respect. I think what we do need is empirical evidence. So this is trying to use the handle of language, ethnicity, and religion together. So this was a longitudinal qualitative study looking at end-of-life care experiences and all the complexities. And one of the messages that was emerging from this was, and we were discussing chaplaincy yesterday, that the Muslims who were dying, and they were saying that the mosques were expecting sort of the patients to come to the mosque. There was virtually no outreach service. And when that was being compared with what was being offered by the Christian chaplaincy service, it was really far, far better in many respects. So we need to really begin to kind of, I think, learn lessons. I want to do a deep dive into one project, just to kind of give you an example of, and so I want to go back to kind of when we had more saner leadership in the UK. So, some of you may recognize this guy, Gordon Brown, a Scottish Prime Minister of the UK. God help us with what we've got at the moment. But he rolled out this program around health checks. So health checks is the largest cardiovascular screening program in the world, with a view to trying to identify high-risk individuals and take steps to try and improve not only their kind of survival, but reduce their frequency of developing these important cardiovascular events. So we're talking about really heart attacks and strokes, but also a few others. And so what we, So what we had was, so this was being rolled out at scale across England, and what we used, or what was being posited, was that what we used was the Framingham cardiovascular risk equation. So who's been to Framingham here? Can I get a show of hands? Yeah, so anything like the East End of London? No. Yeah, it's a Framingham. So this was this is the most famous cardiovascular risk algorithm. It's the most famous risk algorithm in the world. It's derived completely from men, originally. So 5,000 or so men followed longitudinally. So, I think it's a phenomenal resource. I used to drive past this now and again when I was in Boston. And these are the variables that it was using. So, these are kind of credible, plausible variables for those of you who are, so things like cholesterol, blood pressure, diabetes, etc. But then there was a piece of work looking to see how well this performed in the UK population. And surprise, surprise, it was doing pretty poorly. It was greatly over-predicting the risk of cardiovascular events. This is a complicated slide, but maybe I'll just give you the kind of headline. This is, studies, and what they've done is they're stratified by background risk. And so what it was doing, it was over-predicting risk in those with low background risk and under-predicting in those with high background risk. And so what we were getting was really, this was, for our population in the UK was completely inadequate. What it would do is if it was rolled out, it would probably exacerbate any of the disparities because it would preferentially offer treatments to those at low risk, males, for example. So that was problematic. It was taking no account of ethnicity considerations, which are very important. So, lots of issues there. And so improvements definitely more needed. And so what we did is we decided to develop our own cardiovascular risk algorithm for the UK. So we used basically the same model, but we took our primary care data, linked them up with hospital data, and linked them up with mortality data, and followed individuals over the next 10 years. So really kind of traditional prognostic modeling study designs. And so we were able to draw a lot of this from the electronic health record infrastructure. And importantly, we also were able to include ethnicity because this was now being recorded in quite a few of the data sets. And these were the outcomes, so very similar to the Framingham equation. This is a busy slide, but that's all I want you to look at. So the work was done on 10 million patient years of data for derivation, 5 million patient years of data for validation. So using our data from across England, so the high, sort of the affluent areas, the deprived areas, the white areas, the more diverse areas, and as a result, what we have is an equation that is far, far better for our population, unsurprisingly. So that's the one that is now being used by the vast majority of our primary care physicians across the UK. So this isn't only about sort of pointing out problems. What we need to do is try and find solutions. So if we take a clinical example, a fairly typical clinical example, so somebody from South Asia, a woman, would have been catered for poorly using the Framingham equation, now is being classified at high risk and will get treatment on the back of that. What we also offer is for everybody, and this, I pulled off for myself a few years ago, is you can work out your own cardiovascular risk. So making this available at the patient level. So you can go into this and work out your own risk if you so want, but being updated on a constant basis. So that's the paper, if you're interested. And this, I think has contributed to us improving some of our important health outcomes for cardiovascular disease across the UK. And I think we're doing this in equitable ways. And I won't go into the data, but there's an independent evaluation demonstrating that. In the comparable period, unfortunately, your cardiovascular risk profile has deteriorated in the US, unfortunately. So that's for death and then things like premature death. So quite substantial improvements. We've done the same for diabetes. Again, it's a condition that really matters. And the reason why it matters is because people of South Asian and Afro-Caribbean descent are at markedly increased risk of diabetes for the same BMI. It's a very kind of famous slide. John Yudkin is who I learned endocrinology from, so he at medical school. A very famous slide. I think he's Marge, Cordy, you know John as well. Yeah, fantastic work he's done. I think on behalf of populations across the world. Right. Okay, so I'm moving to, I'm going to stop this because it's too confusing trying to navigate two of these things. So what we've done is on the back of that tried to move towards more experimental studies. We were discussing some of this. So this is a randomized controlled trial. We worked in Scotland with our Punjabi speaking South Asians. So these were predominantly people of Muslim, Pakistani and Indian Sikh backgrounds. We worked through mosques, gurdwaras, provided culturally appropriate, religiously attuned, dietary kind of appropriate messaging in a diabetes prevention trial. It cost about £1 million to do this trial. Unfortunately, it was spectacularly unsuccessful. Yeah? So these things need to be tested. I mean, this is why we do trials, because we do not know the answer. We don't do a study, as I was saying yesterday, because we think we know the answer already. That's kind of unethical to do that, I think. Smoking cessation, clearly, as you've seen from the data, there's a kind of a target there. So we worked this time working mainly with Pakistani and Bangladeshi communities. So these are entirely Muslim, focusing on the men. It's a much bigger problem on the men. Working with religiously tailored messaging, working through that kind of health and community infrastructure. This was a pilot randomized controlled trial. It was pretty unsuccessful. On the back of that, we decided we did not have the basis to proceed to a full randomized controlled trial. So yeah, conceptually, absolutely fine. Empirically, so this was around trying to reduce kids' second-hand smoke exposure. We worked through mosques, Quran classes, female sort of Quran classes. So we worked through our infrastructure, trying to reduce second-hand smoke exposure in kids. Again, unsuccessful. So we've abandoned that after the pilot trial. There is now work going on, sort of more globally, that we've recently got funding for, quite a lot of money. And I mentioned yesterday I find it much easier to get money than give out money. I'm a bit of a hoarder. But with this, what I've been asked to do is, I'll come on to that in a second, but in this role, I'm actually distributing a lot more money. So this is a trial that we're doing in Pakistan and Bangladesh, looking at TB and tobacco. This is a really sort of lethal combination. 2,500 people randomized. The trial is now closed, but you'll read the results very soon, but the message is very similar to the kind of previous message, unfortunately. What we're doing is working on respiratory health, and we're doing this in Bangladesh, India, Malaysia, and Pakistan. What we're trying to do is work bottom up, just like you're doing. So this was the kind of group that we pulled together right at the outset. We asked them to articulate what their priorities are, what their needs are. I'm really largely just distributing resources here. So I've got £7 million to spend. It's quite a lot of money. I find it really difficult to spend it. But we're kind of distributing, and that we're working with policymakers, and there's all sorts of studies going on in these countries for the first time, and this was the kind of last foray, and this group has grown enormously. So there's work going on in sort of artificial intelligence, community development, health literacy, all sorts of things, but all emerge sort of bottom up. So most of this will see the light of day, I think fairly soon. I want to sort of move towards the end and think about, well, what does all of this mean? This is kind of my 20-year journey in sort of 45 minutes or so. I think what we desperately need is really to develop capacity and expertise. This is all kind of slightly ad hoc. Some of it's pretty opportunistic. And what I think really do need to do is kind of think seriously, how can we develop some serious critical mass that can go into this for the long term? Because these things are not sort of easily shifted or improved. But the key thing is there is one heck of a lot of headroom for improvement here. So I think we need to do that. We do need to be thinking, genuinely in an interdisciplinary fashion. I think you guys are beginning to do that here. So that's, I think really encouraging. Right, what's this saying? So I think what we also need is, particularly when we're dealing with policymakers and with funders, to be very careful about special pleading. Because, what they have is they have special pleading all the time. And it's an incredible turn-off. The barriers go up straight away. I think what we need to do is try and get a seat round the table and engage constructively and in a genuine kind of way. I mean, offer solutions. Now that's easier said than done because clearly there are relatively few solutions off the shelf. And I think what we need to do is also just think much more broadly than we currently do. Yes, clearly we have a community that's very close to home. But when I was asked to work with, a colleague of mine who was at medical school with and work on, a follow-on book, I had absolutely no doubt about getting involved in this. So we went on and published Caring for Hindu Patients. I learned a heck of a lot in the process. So I think we need to be doing this in a kind of a genuine, inclusive way. So as a result of one of those studies, for example, what we found is that white Scots have the lowest life expectancy. Yes, the Muslims are doing pretty well, the highest life expectancy in Scotland. But my role now is advocacy for this group, and that's what I've been doing. Yeah, we need to be out there for, these are our brothers and sisters in humanity, absolutely. I think we need to try and find opportunities for alignment. And you need to know where the drivers are, because that's where the resource is. And the more you're connected, the more we understand these issues. And I think, some of these are so obvious. And some of these things we were discussing yesterday, there are some very important drivers. What I was surprised with is nobody's kind of begun any of the presentations yesterday talking about your data. What's the burden of disease in the US? These data come from Chris Murray's group. Groups around the world are using these data. They're available for every country, but nobody's kind of discussed any of this. That's where the resource is going to be. What we're now. So go out to Seattle. It's a beautiful city, place, state, Washington, and go and meet with these guys. They're very open to discussion. And I think what we also, it's data and stories. And bringing those together. And I think this was being discussed yesterday, so that was encouraging. And part of the reason why I kind of keep emphasizing data are because what this then turns this away from is a kind of a very subjective piece to a much more kind of objective, because once you have the data, people have to engage. They may kind of raise issues with the data, but it does move the discussion on in a big way, I think. So in conclusion, what we have is a kind of, in the UK, is a relatively young Muslim community. It's diverse, it's still finding its feet. It's got a mixed profile. Considering its heritage, I think it's doing reasonably well. There's still a long way to go. So there's a lot that we need to do there. But I think what we are beginning to see is that there is now some serious engagement with decision makers. Still, there's relatively few people. I think my main role going forward is mentorship. That's what I'm trying to do, to try and bring other people into the mix, because we need kind of disparate voices around the table. I think we've got a lot to learn from you. What I really appreciated was the kind of openness of the discussion. Some of the topics that you're discussing around sexuality, for example, they still remain completely taboo subjects for us in the UK. We're more conservative in that respect. So I think that's encouraging. I'm heartened by that. And I think the fact that you are coming together and you're open and you're receptive, and we can have kind of genuine critical dialogues, for me has been really encouraging. So please feel free to get in touch if I can be of any help. That's the new institute that we're building. Marj and Gordy came and visited us very recently. If any of you want to come and spend some time there, you'll be very welcome. So I'll just stop there, and I'm very happy to take any questions or comments. Thank you.
I did enjoy very much your presentation, and I'm curious, how can you take, within the research that you have done or and you studied, talking about the Pakistani, Indian, and Bengali population in the United States, in terms of the fact when they immigrated to the UK was because of the British occupation and they came to do the job service has not been done, versus the population of Indian Pakistani Pakistanis and Bengali living in the United States who are mostly highly educated, the health sector or health well-being of Muslims living in the United States?
Yeah, so I mean, I think it's a very different migration history to the US, clearly, and I mean, and your Muslim population here is, I mean, obviously much more diverse. So I don't think there's any simple lessons. And I think that the kind of wider point I'm trying to make is that what you need to do is develop a bit of a theoretical framework as to how do you get the best picture possible of what the Muslim health profile is at the national level, at the kind of state level, and at the kind of city level, for example. I mean, one way to that is probably going to be using ethnicity or race as you use it here. And that might not necessarily be just focusing on the Indians, Pakistanis and Bangladeshis. But if you do focus on that population, that's probably sort of amongst the most affluent strata of the Muslim population that you have in the US. So what you'd have to do is, so I mean, there's quite a lot of theorizing to be done here, is my point.
Yes, I think within that Muslim population here, like South Asians are the highly educated ones, but the ones who got the dirty jobs, basically, mostly a lot of like people immigrating from North Africa and other parts of the Middle East, and also from like Somalia, from Ethiopia. So it's really quite interesting to look into the experience of how could. The other thing that is really bothering me about the population also, how can you encourage the Muslim population to come out and you know, participate in the census, for example, or participate in to be counted. We have, unfortunately, a situation where with the Islamophobia and all that stuff, a lot of reservation about coming forward and identifying yourself as a Muslim or from a minority because of the politics that have that exist in this country. So it's like a dilemma that you're shattered in between as an advocate of, you know, on the community.
Yeah, so I mean, these are really complicated, and these are some of the things that, I mean, I certainly, from across the pond, can't offer solutions to. I mean, I can certainly help you think through some of these issues. And I think we're in a kind of a political moment, and I mean, this pendulum swings one way and the other. But I mean, overall, I mean, I think this is a phase that we're in. Inshallah, it's kind of a temporary phase, both I mean here and on our side of the pond. So it's kind of, I mean, I think longer term planning. But going back to, if you were to look at sort of Pakistani and Bangladeshi, I mean, if the assumption here is the majority of these are kind of professionals who've migrated, they're in professional jobs. And so if you were to look at their health profile, then your assumption would be that, I mean, the health of the Muslim population in general across the US is probably going to be less good than that. So that's probably your ceiling, would be one way of kind of theorizing about this space, I think.
I guess I'm wondering how much, like what direction do you think the acquisition of this research should take? So I think a lot of the times we have the impulse as like a small minority Muslim community to, I guess, approach data collection in more like third space kind of orientation, where like the platforms that we publish in are not necessarily like the most esteemed or well reviewed platforms. I'm wondering if you think that we should direct our attention and our like focus, our finances towards working with more established institutions here. Obviously, like bigger universities or whatever. Obviously, the problem is, you know, we don't have maybe as much interest from those institutions to uplift our voices. But at the same time, there's like a kind of credibility issue, but like we're confronted with the need to acquire data. So I guess like we're kind of stuck in those two directions that I'm not sure which direction the Muslim community here should take.
So the question is, what direction should we take here in the US? So, I mean, a lot of the work's being done in the third space. It's kind of bottom up from the ground. Or do we begin partnering with the major academic institutions and publishing in the kind of more, I mean, the bigger mainstream journals? I mean, is that a reasonable summary? Okay, so my kind of inherent bias here is that I think it's about doing a few things and doing those really well, and being strategic in what we try and do. Because I think if we can get into the mainstream medical discourse, it does really begin to change the equation. That's certainly my experience from the UK. So I think that is, but what I do understand is, a lot of the questions that you guys are posing, there's probably no way that academics themselves would be coming up with those questions. So these bottom-up questions, capturing them is really important. And if we could find some kind of meeting point in the middle. So what I guess and I'll just speak honestly, what I'm rather disappointed with here is that there's some really great questions. This institution is recognised across the world for its work on social justice. But where are the kind of academics from the University of Chicago in this discussion? Why aren't they here engaging in that discussion? Because what they could do is they could take your questions and work with you and refine those and improve those and help create, because otherwise, how on earth can we expect people working in community organizations to develop the kind of research skill set that's needed? It's impossible. So it has to be a kind of a partnership model, and maybe Asim, you can pick up on that. If you can, I don't know. I'm less. Obviously, I can speak much more freely than you can. All right. Are there other questions? Yeah.
So my question is, one of the challenges that I and some of the others have faced is when we want to add the name, the category of Muslim on some of the larger databases. There's been pushback by the Muslim lawyers within the community, the civil rights individuals saying, we don't want that data to be categorized because it can cause other additional unintended consequences. So how do we balance that?
Well, can I make a comment? That was my question. So I want you to know that in the United States, it's prohibited by law on the census to have the religion category. So I was going to raise that question. You said we open up a space, right? But it's prohibited by law here to do that in the national census. So we can have that census, but you won't count it as a religion.
Yeah, so and so none of what I'm sort of saying is about simplistic solutions. You can't just pick these things up and transfer them to other contexts. And there's a reason why, there's that prohibition in the US context. There's a history that we need to understand. I remember, one of the things I work on is working these large data assets. What's been absolutely transformative for us in the UK has been a unique identifier. Because what we can do is we can link up data assets across the entire life course, and you can begin to answer all sorts of questions. It just really sort of multiplies the usefulness of these data. I went into Health and Human Services in DC and had a conversation with the head of the Office of the National Coordinator there to say, well, why don't you have a unique identifier? We had to step outside of the building to have that conversation because it was an illegal conversation in that building. So I get that, and I said, well, what on earth is this about? And the answer that Farzad gave was Nazi Germany. So, we have to understand the context. We have to. That said, I think there are opportunities for us to come together as faith communities, minority communities, to think about some of these issues. And it may be that there's a kind of a surrogate that we can come up with. Because this issue about us joining census data with health data was illegal. It took years of work. That's why nobody else in the world has done this. So these things are not kind of fixed in stone. You have to make the case. You have to be persistent. I think you have to be gracious in terms of understanding, really understand what some of the reservations are. Can those be mitigated? So, for example, how do we mitigate some of the risks here? When we've joined up census, we suppress data if there's small numbers. I've not shown you any Bangladeshi data because we've suppressed those data, for example. So you come to kind of compromise positions. I don't have any simple answers, I'm afraid. We have to grapple with these issues. There was a question over here, I think. Yeah.
So I was interested in basically looking at the trials that you talked about where you were unsuccessful in trying to intervene for certain diseases. So my question is, have those interventions been shown to be effective in other populations, and why do you think the population that you studied was so different and it didn't seem to work?
Yeah, so I mean again, there's different answers. So the diabetes prevention trial was modeled on a very successful diabetes prevention trial, the first of its kind, done in Finland. Jacko Tumalutu is the principal investigator, so we worked with him, adapted that intervention in the populations in question. And I think the conclusion that we've come to is that because there's these kind of difference in body composition, as I kind of tried to show with that slide, to achieve the same effectiveness, what we need to do is have far greater weight loss, far greater levels of physical activity, far greater levels of dietary modification in this population if we're going to get the similar effect as to the white European population. So these are things, the kind of a knowledge base that we work on incrementally. Where we're working with mosque-based infrastructures, we have absolutely zero. I mean, these are the first trials of their kind in the world in using mosque-based infrastructure. What we've tried to do in doing that work is we've tried to learn from the faith-based trials done through the church infrastructure in the US, because there's quite a tradition of that, I mean, quite a body of that work. I mean, I think where we're probably failing is that there's probably been too much emphasis on religion. I mean, yes, I mean, this is a kind of a very selective group, I mean, deliberately, I mean, kind of, but actually for the vast majority of Muslims, religion matters a bit. Yeah, I mean, that's the reality. It's kind of one aspect of their existence. I mean, other aspects matter. And so, I mean, this intersectionality issue, I think, is going to be really, I mean, we just have to be honest about that. For this group, I mean, I know it matters, I mean, a real lot, it matters to me. But for the vast majority of, you know, I think it's important, but there are other things that are important as well, and we need to kind of factor those issues into. Yeah, okay. Good, okay, I hope that's been useful. Thanks very much indeed, thank you.